Welcome to part 2 of the protocol rollout for November 1st, 2025. Unfortunately, we had 3 protocols waiting at the state to be finalized and approved, and they were not included with the first rollout we did. So we're going to quickly go through these 3 protocols so that you're up to speed and ready to go on November 1st. My name's Bonnie Kincaid. I'm the Executive Director of the Oakland County Medical Control Authority.
Hi, I'm John Toyd. I'm the Director of EMS Operations for the Oakland County Medical Control Authority.
Hi, and my name is Amy Welline, and I'm Administrative Coordinator for the Oakland County Medical Control. The first protocol that we are going to cover is 1.100, which is Diabetic Emergency. There isn't much change to this protocol, really only an added reference of 7.23 vascular access and IV fluid therapy. And there's also a bit of a change that the state had us add, was that if a patient is able to swallow and 3 months old or older, that you're able to give small amounts of oral glucose. There is a reference at the end of the protocol for refusal if needed.
The next protocol is Protocol 7.6, Dead on Scene and Termination of Resuscitation. There's been a lot of discussion and back and forth about this protocol between the state of Michigan and Oakland County. We've added that if ROSC is not achieved after 30 minutes of ALS time, you're supposed to contact medical control for continued resuscitation on scene, 2, to initiate transport, or 3, to possibly terminate resuscitation. However, the state suggested that we have a script for what should be said to the hospital, and also a definition of what ALS time is. ALS time is defined as the time that ALS care began and ALS procedures were performed. So the hospital communication will clearly state the age and gender of the patients, assessment findings for the patient, current end tidal CO2, the end tidal CO2 trend through the resuscitation. So did it start at 30 and end at 8? Did it start at 8 and end at 30? The medical history of the patient, the initial rhythm, and then the current rhythm with changes to shape, rate, etc., if it was the same as the initial rhythm. For PEA, describe the rhythm. PEA is actually a clinical condition, not necessarily a rhythm, because the rhythm is the electrical activity. PEA is a clinical condition that there's no blood pressure involved or a very, very low blood pressure involved with that rhythm. Treatment, including ALS time, estimated time to receiving facility with patient loading time, and any other information considered pertinent. The reason for all of that information is so that a collective decision can be made between you and the physician you're speaking to on the phone or radio. You can consider termination of resuscitation if the patient is in a systole in all 3 leads. And the new part is you can consider termination for PEA if the patient is not in a normal complex PEA with a rate greater than 40. So that means wide complex, less than 40, and the end tidal CO2 is less than 10 millimeters of mercury. That's key. There are some big changes. You're going to want to look at this protocol and read through it yourself.
And the last protocol we need to cover is 7.23, vascular access and IV fluid therapy. The major change here is that if you choose to use lactated ringers, there needs to be a thought process on if you're going to give a medication that you need to flush prior to the medication and after the medication administration. The reason that you need to flush prior to and after the administration of any medication is the potential for precipitate to occur, which is a chemical reaction between the lactated ringers fluid and the medication.
Thanks for joining us for this briefing today.